Our next speaker today is Karen Ciclosi-Rary. She is a certified genetic counselor at Johns Hopkins University in the Institute of Genetic Medicine. She's been an active participant in the Cystic Fibrosis Foundation-funded CFTR2 project, a project that has contributed significantly to the phenotype-genotype correlations in cystic fibrosis and established the functional validity of a number of the variants in the CFTR. Ms. Rary.
Thanks very much for the introduction. I'm going to be talking today about cystic fibrosis carrier screening and focusing on the genetic counseling aspects surrounding that. I have nothing to disclose related to this presentation. So the first thing that I wanted to just bring up are the resources available to you when thinking about genetic counseling related to CF carrier screening. Several of the national organizations for genetics have published either policy statements or guidelines related to CF carrier screening, including the ACMG, and this guideline was recently reaffirmed in 2013. There's also a committee opinion from the American College of Obstetricians and Gynecologists, update on carrier screening for cystic fibrosis, and they've listed several of their recommendations and guidelines. And most recently from the National Society of Genetic Counselors, recommendations were published on molecular testing for CF carrier status. So these are all publicly available, and you should be able to use them in your practice when dealing with CF carrier screening. So I want to launch right in with who should be offered CF carrier screening, and the short answer to this question is everybody. Contrastingly to previous recommendations, it's now recommended by ACMG and ACOG that every preconceptional or pregnant woman be offered CF carrier screening, regardless of race or ethnicity. It used to be mostly recommended to people who were Caucasian or of Ashkenazi Jewish descent, and these guidelines have been updated that really every woman should be offered CF carrier screening. If it comes up positive, typically her partner is then offered screening as well. However, if somebody is already pregnant and time is of the essence related to pregnancy management, pregnant women and their partners may be offered screening concurrently. Other groups that should be offered CF carrier screening are specifically individuals with either a family history of cystic fibrosis or a family history of identified CF carriers, as well as partners of mutation carriers or partners of individuals with CF. And this bottom group may benefit from a referral to either a genetic counselor or other genetic specialists to discuss carrier testing, since they've got a little bit different risk associated with it. So in pretest counseling for cystic fibrosis carrier screening, this is sort of just a bullet-pointed list of the things that should be covered. The first thing that I usually think about doing when talking to a patient is finding out what they already know. Some people have never heard of CF, and other people may have a next-door neighbor with it or have preconceived notions of what the condition is. So I usually try to get a baseline of what somebody already knows about the condition, and then try to tell them things about it. So what are the range of symptoms, differences in phenotype between what we think of as classic CF versus somebody with milder symptoms or even a CFTR-related disorder. Potential treatment options should also be mentioned, since we know this is a disease that does not currently have a cure, but there obviously are a wide range of treatment options, particularly with the newly FDA-approved treatment of Kalydeco. And quality of life related to CF and CFTR-related disorders should also be discussed. From then, an estimation of CF carrier frequency based on population risk and family history should be determined. And then choosing the appropriate carrier test and limitations of testing should also be discussed. And this bottom section are things that I'm going to go into a little bit more detail in this presentation. The top of this list are just things that should be kept in mind to bring up. I'm not going to reiterate what all of those things are. I also wanted to make a quick note about people who may decline CF carrier testing. This is obviously everybody's personal choice, and it's absolutely fine for someone to decline testing. But as a genetic counselor, it's my job to make sure that a patient makes an informed decision. And some people may decline because they have misconceptions or a lack of education about the condition. Two of the most common reasons that people decline testing are either no family history of CF, or that they would not consider a change in pregnancy management or would not consider pregnancy termination if a fetus were to be diagnosed with CF. And the only thing I would make sure that people know is that most recessive conditions occur with no family history of the disorder, and so it's not uncommon for a child with CF to be born into a family where there's no other diagnosis. And for even people who would not consider pregnancy termination, sometimes people would like some sort of prenatal diagnosis or knowledge of the risk of a genetic condition simply to be prepared for the possibility of that and to make a perinatal plan. So again, perfectly fine for people to decline carrier testing, but just some things to keep in mind to make sure they're making the decision with information. So I want to launch into types of available CF carrier screening, and I think you're going to hear about this from other people involved in this webinar, so I'm hoping that reiteration will help. The first that most people are probably most familiar with is the ACMG approved or ACMG recommended 23 mutation panel. This is pan-ethnic. It's based on the U.S. population specifically. And as you can see from the diagram below, which represents the CFTR gene, those are the 27 exons and the introns connecting them. The 23 mutation panel looks in 23 specific spots in the CFTR gene for mutations that we know cause CF. This is the most basic carrier screening that's available. The second sort of tier up from that would be something called an expanded mutation panel. And this can contain anywhere from 24 mutations up to 100 plus. And you can see from the diagram below, this has the same idea as the 23 mutation panel. We're looking in very specific areas of the gene for mutations, but there's just more of them that are looked for with an expanded mutation panel. And this may have a greater sensitivity for non-white ethnicities. And the last type of CF carrier screening available is sequencing, with the possibility of deletion duplication testing as well. This type of testing reads the entire coding region of the gene, as well as the intron and exon borders, and certain specific intronic regions. So the areas between the exons may be assessed if known mutations exist in those introns, and there are a handful that we know about. The difference with this type of testing is that it's distinct from the panels in that it doesn't target known mutations, but actually looks for anything that's different from the wild type. If we look at these types of testing side by side, just to get a better idea of comparison, and I think you'll see similar slides with other presenters, we can see that for the 23 mutation panel, it has a sensitivity that's variable by ethnicity, residual risk, so that's the risk that your patient could still be a carrier after negative testing. That's reduced, obviously, with negative testing on the 23 mutation panel. You really shouldn't get any sort of uncertain result from this panel because all of the mutations on it are known to be CF causing, and insurance is pretty likely to cover this type of testing. If we move into the expanded panel, the sensitivity goes up because we're looking for more mutations. This, again, varies by ethnicity. The residual risk is, again, reduced further because we're looking for more mutations. And the uncertainty of result is pretty unlikely because most of the mutations are put onto this panel because they're disease-associated. But they may have a variable phenotype, and there may not be as much phenotype information available about all of the mutations. Insurance is also probably likely to cover this type of test. The last test that I mentioned on the previous slide and here is sequencing plus or minus deletion duplication testing. Sequencing picks up about 98 to 99% of the mutations that are in CFTR in the coding region and those intron-exon borders. The residual risk is lowest of all of these types of testing, but the uncertainty of the result is higher because this type of testing picks up novel variants or variants of unknown significance that maybe people don't know how to interpret. So you may get a result that you're not sure exactly what it means. And insurance may balk at this type of coverage. The turnaround time is typically longer than in panels. Deletion duplication testing, looking for large regions of the CFTR gene that are repeated or deleted, may be added on to sequencing. It's a different testing methodology, and about 2% or so of CFTR mutations are thought to be deletions or duplications. As I mentioned, there are limitations to any type of CF carrier screen. The residual risk is basically the chance that a person could still be a CF carrier after negative testing. And the residual risk should be either specified on the lab reports or you can calculate it. It varies by ethnicity. But the take-home point from this is no matter which type of screening test is performed, there will always be some sort of residual risk. And I'll talk about this a little bit later as well. But this is just an example to show you that if somebody's pre-test risk to be a carrier is 1 in 25, if they then have a negative screening test, the residual risk listed on the report for this example is 1 in 200. So you can see it hasn't gone to 0, but it has dramatically decreased. This is from the 2011 American College of Obstetricians and Gynecologists Committee opinion, and this basically shows the carrier risk before testing, detection rate, and residual risk for several of the U.S. Ethnic groups. This is based on the 23 mutation panel that's recommended by ACMG and ACOG. And the important point to mention here is that the carrier risk before testing, these are estimates. For example, the 1 in 58 of Hispanic white carrier frequency is based on generally generally accepted consensus numbers based on population studies, looking at mutations represented in CF patients, et cetera. These may not be exact numbers, but they're generally accepted and kind of what we use as a basis. So the residual risk, as you can see, is listed by ethnicity in the far right column. You can actually calculate the residual risk by multiplying the carrier frequency by 1 minus the detection rate. And so the example that I've given here is for Hispanic whites. So if we start with a pre-test population risk of 1 in 58, and we multiply by 1 minus the detection rate of 0.72, you get 1 in 200. So that's the chance that somebody is still a carrier after negative testing. So more on residual risk. As test sensitivity increases, the residual risk decreases. This you probably saw from the side-by-side comparison of tests, but I wanted to show it a different way in this diagram to the right. So this is an image adapted from Integrated Genetics CF Plus carrier screen, where they look at 97 mutations, as opposed to the ACMG23. So you can see that for the Caucasian groups, the ACMG23 mutation panel leaves most people with a residual risk of 1 in 200 if they test negative. But if you use the 97 mutation panel through Integrated Genetics, you get a residual risk of 1 in 343. So you can see that when they test for more mutations, as that test sensitivity rises to 93% for Caucasians, the residual risk goes down. And you can see this trend repeated in the African Americans and Hispanic populations that they also list in this diagram. I also want to mention interpretation uncertainty with sequencing, and I touched on this a little bit in the side-by-side comparison. But as we already talked about, test sensitivity increases and residual risk decreases, but the interpretation uncertainty, or the possibility of getting a result that's uncertain to interpret, increases when you go up in test sensitivity. So as I mentioned, sequencing may identify variants that are novel of unknown significance. So in general, the residual risk of being a carrier is lower than before testing because many of the CF-causing mutations were not found, but it may be unclear if an identified variant actually causes CF. If it doesn't actually cause CF, that person's probably not a carrier. The unfortunate part about this is sometimes this can't be sorted out, and patients may have a difficult time accepting the uncertainty of their results interpretation. So I also wanted to launch into a few different types of results that you may receive after offering CF carrier testing. The first would be the result that we all hope to get, which is negative carrier testing. And in this case, great, your patient's risk for being a CF carrier has decreased. So in this situation, things that would be important to discuss are the residual risk to be a carrier. We've already talked about that a lot. It should be listed on the report by ethnicity, or you can calculate it as I've shown. And something else that's helpful for some couples to hear is the residual risk to have a child with CF. And so you can do this by using the residual carrier risk and the population risk for the partner who was most likely not tested, and in this example is not tested. So the example I'm giving is a Caucasian screen-negative woman, so she was screened using the ACMG23 mutation panel, and her Hispanic partner who was not CF carrier screened. And as a reminder, we're going to use calculations for recessive inheritance. So the first number that we're thinking about is the residual risk of the white woman that was tested and had negative CF carrier testing. And again, this number is a pretty good estimate based on the carrier frequency and the detection rate. So we multiply her risk to be a carrier of 1 in 200 by her partner's risk to be a carrier. And we got this number straight off of the carrier frequency list from that publication. So 1 in 58 is the population risk for somebody of Hispanic origin to be a carrier for CF. And then we multiply by their chance to have a child affected with CF or affected by a recessive condition. So if they were both carriers, the chance that they both pass on their mutations is 1 in 4. When we multiply all of these things together, we get a final number of 1 in 46,400. This is an approximate risk for this particular couple to have a child with CF. Not everybody is good with numbers. Sometimes it's really helpful to calculate this out for people, maybe convert it to a percentage so that they can try to get a better grasp on what this means. Another type of result that you may encounter is when you have a mutation identified. And the mutation may be very straightforward. So the examples that I've given here are delta F508 or F508del, G551D, W1282X. There's many more, but these three are examples of mutations that are expected to cause CF when inherited with another CF-causing mutation. These are pretty straightforward. In this case, your patient is a CF carrier and is at an increased risk for having a child with CF. It's appropriate to offer carrier testing to the partner. Some partners in this situation may want a more sensitive screening test than was originally done, such as either an expanded panel or full gene sequencing, once their partner has been identified as a carrier, so that they can increase the chance of making sure that they're negative. And in this case, a referral to a genetic counselor or other CF specialist may be appropriate. The last type of result is a more uncertain one, and this is something that you also might come across. So if the result is not straightforward, and in this I'm showing the picture of the arrows again, so this is likely a result that's come from increased test sensitivity, so lower residual risk, but we're dealing with that interpretation uncertainty. And two examples of this are when you either have more than one variant identified or a variant of unknown significance identified on the report. In this case, your patient may be a carrier for CF and may be at an increased risk to have a child with CF. But in order to figure that out, correct interpretation of the variant or variants is essential. Carrier testing for the partner may be recommended once this is sorted out, and referral to a genetic counselor may also be appropriate. I just want to mention some resources for variant interpretation. So I said on the previous slide that figuring out what your variant does is important to figure out if it causes CF. There's a couple online resources. The CF mutation database is run through the Hospital for Sick Children in Toronto. This has been around since shortly after the CFTR gene was cloned. And it's data that's collected mostly from labs doing either diagnostic CF testing or CF carrier testing. And they basically report when they find a mutation. So there's limited interpretation of the effects of different mutations in the database. CFTR2 is the other online resource that's fairly new. And data collection in CFTR2 was done from CF clinics and registries worldwide. Variant interpretation is available, and I'll get into that on later slides. Other resources for variant interpretation include the literature, so just doing a search to find out if there have been any publications about your mutation seen either in carriers or in affected people. The testing lab may also have more information. They'll give you the whatever report you've received is going to have something on it, and it may say this is a variant of unknown significance. But you may be able to speak with somebody from the testing lab to see if they've ever seen the variant before, what were the details of that case, etc. This doesn't always yield a lot of information, but it can be worth a try. And another resource is a CF genetic counselor or other CF genetic specialists. There are several CF genetic counselors in the country that work specifically with CF, and they're probably a good resource. You can find these people through NSGC's website. I want to talk a little bit more about CFTR2 specifically. CFTR2 stands for the Clinical and Functional Translation of CFTR. So it's sort of like CFTR squared, but with a 2. And the goal of this project and website is to assign disease liability to different CFTR mutations. We'd like to call them CF-causing, non-CF-causing, or a mutation of varying clinical consequence. And the process used to do this is using clinical data, functional testing, and population and penetrance data to determine the effect of these different variants. If we're using the CFTR2 CF-causing mutations as a panel, the detection rate is higher than for many other panels. It gets about 96%, so 96% carrier detection rate. This is pan-ethnic, so this is not broken down by different ethnicities such as white, Hispanic, Ashkenazi Jewish. So it's pan-ethnic, but it is primarily based on data from the US, Canada, and Europe. That's one use for CFTR2. Another use is using the CFTR2 data available online to interpret a variant that you might have found on carrier screening. So just something to keep in mind, just because a mutation is observed in a patient with CF does not automatically mean that it's the cause of disease. And this was one of the reasons that CFTR2 chose to use a multifaceted approach to determine disease liability. So functional testing that was done as part of the CFTR2 analysis can be a valuable piece of information when deciding if a mutation is likely or not likely to cause CF. And we know from scouring the literature and just general consensus of experts in the field that mutations showing less than 10% of chloride conductance, so less than 10% of wild-type CFTR function, are likely to cause significant CFTR dysfunction. So mutations showing less than 10% of chloride conductance are very likely to be CF-causing mutations. This is another way to use some of the CFTR2 data that's available online. And more information about CFTR2 is available in a recent publication by Sosna et al. I want to switch gears and go back to different types of results that you may see. So we've talked a little bit about straightforward results, not so straightforward results, and ways to interpret variants. Another type of result that you may get is when you have more than one variant present on your lab report. So genetic testing is very good at showing what is present, but it does not easily show you where it is. And so in the two pictures here, you can see on the left that this is an example of two mutations, G576A and R668C, that are in cis. This means they're on the same chromosome or in the same copy of the CFTR gene. Alternatively, you could imagine that these two mutations are actually on separate copies of the CFTR gene or in separate alleles, and that's referred to as intrans. So genetic testing can tell you that these two mutations are present, but it doesn't tell you which of these two pictures show the correct orientation. It's known that some mutations do travel together, and these are called complex alleles. If they're on the same chromosome or in cis, they're basically acting as one mutation, and some common examples of those are shown below. So when your carrier screening reveals two mutations, you need to sort out the phase, and the phase is whether or not they're in cis or trans, and phase can be sorted out by doing familial testing, testing somebody else in the family to see if they have one or both mutations. If you determine that your two mutations are in cis, so they're on the same copy of the CFTR gene, you need to assess the effect of the mutation combination. Checking each of them individually isn't all that helpful because they're most likely going to be working together. So in this case, the individual is likely a CF carrier if the complex allele is CF causing. And the example I've shown here is a CF causing complex allele, so this person would be a CF carrier. If the mutations are in trans, there's really one of two results, or one of two interpretations. The first is that one of the variants may not be CF causing and may in fact just be a polymorphism. So the example here is G551D. We know that's a CF causing mutation. We also know that M470V, shown in the other allele, doesn't actually cause CF. And the reason that we know this is because there's been enough people studied that have mutations very similar to this that don't have CF. Now recall, because CF is a recessive disorder, we expect that somebody with a mutation on each allele is going to have disease, unless one of those mutations doesn't cause CF. So in this example, this person is also a CF carrier. A less common scenario that you might run into is that an individual with two CFTR mutations that are confirmed to be in trans may actually be mildly affected and undiagnosed. And if you ever suspect this possibility, if there are two possible CF-causing mutations, that person should be referred for a clinical evaluation. In this example, one of the mutations, D1152H, is known to produce symptom variability, and somebody may have just thought they had asthma or a bad cough or be prone to lung infections, but not actually be diagnosed with CF. If you run into this case, that person needs a clinical evaluation. If you have determined that both parents are CF carriers, we know from recessive inheritance that that couple has a 1 in 4 risk of having a child with CF, and they should be referred to a genetic counselor. If they're pregnant, that person will probably offer them prenatal diagnosis. If they're not pregnant, they may be offered pre-implantation genetic diagnosis, or PGD. Couples who are both carriers may benefit from a referral to a local CF center or a CF clinic to learn more about clinical care for the condition. And some may want to speak with a parent of a child with CF. Anticipatory guidance that we think about in this type of case are making a prenatal plan if the couple is already pregnant or planning to get pregnant, serial ultrasounds that could look for echogenic bowel. It's also helpful to just warn parents of the possibility for neonatal surgery related to meconium ileus, and helpful to plan for neonatal sweat tests, newborn screening, and/or genotyping to very quickly figure out if this child is actually affected. I also try to make sure that I mention that carriers of CF may have a positive newborn screen, so parents should be prepared for that fact. And I also want to briefly mention prenatal diagnosis for CF. This should be offered when both parents are identified carriers of the condition, and it's available when familial mutations are known. So if we already know the mutations that mom and dad are both carrying. The two main types of prenatal diagnosis include chorionic villus sampling, or CVS, which is done at 10 to 12 weeks of pregnancy, or amniocentesis, which is done a little bit later at 16 to 20 weeks. And these are both ways to determine for sure whether or not the fetus has CF. If a prenatal diagnosis of CF is made, it's appropriate to refer that couple to a CF clinic for further discussion about care after birth. And it's important to prepare the family for the possibility of meconium ileus at birth. I want to switch gears a little bit and talk about family members of either CF carriers or affected patients. And the bottom line here is that once a carrier has been identified, other family members are also at risk to be CF carriers. In this pedigree example, we have mom and dad who have both been identified to be CF carriers. They actually have 2 sons, one of whom is affected with CF and the other one who is not. In this example, the people at risk to be CF carriers, first off the bat, are mostly mom and dad's siblings. So first-degree relatives, and in this example siblings, of carriers have a 50% chance of also being carriers. If we think about second-degree relatives, such as nieces, grandparents, half-siblings of carriers, these people have a 25% chance, or a 1 in 4 shot, of also being carriers. Unaffected siblings of affected patients have a slightly different chance of being carriers. They're at a 67%, or 2/3 chance. And the way we get this number is if we think about recessive inheritance, we know that this particular mom and dad have a 1 in 4 shot of having an affected child, a 2 in 4 shot of having a child who's a carrier, and a 1 in 4 shot of having a child who's neither a carrier nor affected. In this case, we know that the sibling does not actually have CF. He's not affected. And so we can get rid of that 1 in 4 possibility of being affected since we know he doesn't fall into that category. That leaves a 2 in 3 chance that he's a carrier and a 1 in 3 chance that he's not. And so in this case, that's where we get that 67%, or 2/3 chance of an unaffected sibling being a carrier. You may also find yourself counseling not necessarily a family who has an affected child, but somebody where there's already been a carrier identified. And in this case, and in the case before on the previous slide, it's very important to determine the familial mutations that are running in the family. Please, please, please get a copy of somebody's genetic testing. Do not trust your patient's memory. Even if they are the smartest person you've met, if they're not familiar with genetics, they may not realize that switching a number or switching a letter or moving a period or a space can really affect what a mutation means. And so it's very important to make sure that you're looking at a copy of a lab report that tells you what mutation is running through that family. In this case, you also may want to refer someone to a genetic counselor for further discussion. And it's important or appropriate to offer more than just targeted mutation testing. So in this example below, we have mom who's an identified carrier of a CF mutation. Her daughter is currently pregnant and is seeking carrier testing. We know, because mom brought her lab report in, that she's a carrier of a mutation called W1204X. This is a mutation that is a known CF-causing mutation, but it's not on the 23 mutation panel through ACMG. So you might look at this and think, okay, we just need to test the daughter for W1204X. If she doesn't have it, she's home free. It may not be quite that easy. If I tell you that this family is white, dad also has a 1 in 25 risk to be a carrier. He may or may not have ever been tested, so he may not know. If he is a carrier, he could have passed on that mutation to his daughter. So if you only tested for her for W1204X and dad was a carrier and he passed on his mutation, you wouldn't find it. And so in this case, it's very appropriate to offer more than just targeted mutation testing, but of course make sure that whatever mutation is known to be in the family is included with whatever testing is offered to this person. So in summary, to wrap everything up, the take-home points that I want you to remember from this are that there are multiple types of CF carrier screening tests available. We've talked about the arrows, so when sensitivity goes up, residual risk goes down, but the possibility of uncertainty also rises, and greater sensitivity increases when you look for more mutations. So looking for more mutations means residual risk goes down, but you might get an uncertain result. Correct interpretation of variants that you might get on a screening result is key. They may be very straightforward, such as delta F508 or G542X, some of the well-known CF mutations. But you may also find yourself getting a report that has either multiple variants identified, a variant of unknown significance, or the like. And in this case, you'll need to either sort out the phase of the multiple variants. Are they traveling together or separately? And is there any other available information about a variant of unknown significance? Are you able to determine whether or not it actually causes CF? And I would just remind you to use your resources. So the online resources we talked about, such as CFTR2, the CF mutation database, and referrals to either CF genetic counselors or other CF specialists. Point being that family members of carriers or affected individuals may need a more specialized risk assessment, especially when they have known familial mutations making their way through the family. That's all I have for you today. Thank you very much for allowing me to be part of this webinar.
All right. Thank you very much, Karen. That was a